Hello, everyone. I'm Tejaswini. I'm one of the PhD students with the University of Adelaide in ICU Nutrition, and I'm here to talk about nutrition in the critically ill. Critically ill patients are at a higher risk of malnutrition, mainly because we do not want them to become overweight and not be able to get out of the bed. Neither do we want them to lose all the muscle and become malnourished at the end of their critical illness. In this presentation, I would like to briefly cover on the guidelines on nutritional support in these patients. We will look at enteral feeding, parenteral feeding, fluid and electrolyte management in these patients, and the calculation of nutritional delivery. These patients are at risk mainly because of these reasons. They have increased nutrient losses. They might be nil by mouth. They might have recent alcohol abuse problems. They might have a recent weight loss because of malignancy. They might be grossly overweight or underweight to begin with. And they might also have increased nutritional requirements because of the diagnosis like trauma, burns, sepsis patients. They might be taking medications with anti-nutrient properties like the GLP-1 receptor agonist, which can actually delay gastric emptying, and they might not absorb any of the nutrition that they actually take. There are several tools which are available to assess nutritional status in these patients. The one which is commonly used is called subjective global assessment, which involves a history and physical examination. You look for the recent history of weight change, their dietary intake, GI symptoms in the last 2 weeks, functional capacity, and then its relationship to nutritional status, mainly the disease diagnosis like sepsis, burns, and trauma, like I said, and then the medications that they're on, any allergies, and previous surgeries. You also look at a physical examination, looking at loss of subcutaneous fat, muscle wasting, mainly quadriceps and deltoid, and you look for edema, which tells us about their protein intake status, mainly ankle, sacral, and sacral edema, and then you look for ascites in these patients. There are several other methods of nutritional assessment. Traditionally, it used to be assessed using something called the body mass index calculation, BMI, basically weight divided by height in meter square, and anthropometric measurements, as I said. And you can also look at the laboratory assessments. I'll talk about this in our next slides. And then, as I said, you do a subjective global assessment with history and physical examination, which is more reliable. The rationale for laboratory assessments involves looking at electrolyte status, mainly because once you start feeding them, you don't want them going into refeeding syndrome. You look for albumin, which has a half-life of 20 days, which can represent chronic nutritional status. You look for pre-albumin, which can be a marker of acute nutritional status with a half-life of 1 to 3 days. You look for transferrin and the coagulation profiles, which can represent synthetic function of the liver. You look for the fat-soluble vitamin levels and water-soluble vitamin levels. And then you see whether you can label the patient as either well-nourished or moderately malnourished or severely malnourished. And this will help you prescribe your nutrition properly. You can do other assessments like assessment of metabolic activity, hydration status, and you look for signs of micronutrient deficiency so that you can supplement those nutrients. And you need to get a speech pathologist review in patients who are able to take oral intake to ensure that they're able to swallow. There are several studies which on nutrition, but they do not actually report a standardized body weight when you're calculating nutritional requirements. The one that I would like to highlight here is the ArtsNet study, which used ideal body weight for calculation of its nutritional requirements when they did in ARDS patients. And since then, we've been using ideal body weight in the same formula which was used in the ArtsNet study way back in the 2000 to calculate nutritional needs. When you calculate nutritional needs, you look for calories, proteins, fats, electrolytes, and the hydration status. The first thing is the energy requirement or the calorie requirement. In most of our diet, we usually take about 70 to 75% calories coming from carbohydrates, around 20% coming from fats, and 10 to 20% coming from proteins. So in ICU, we tend to follow the same thing, but we do not ever give more than 40 to 50% calories from fat. You have heard of ketogenic diets being used in epilepsy in the past. Even then, we don't exceed 40 to 50% of the total energy needs coming from fats. And proteins should be calculated as a calorie source. This thought has changed in the last decade. So we should not be overfeeding our patients, and thus we use proteins as a calorie source as well. The gold standard for calculating calorie requirements is indirect calorimetry, and it measures respiratory quotient and thus calculates the calorie requirement. Respiratory quotient is the amount of carbon dioxide that a patient synthesizes divided by the amount of oxygen that he uses for the breakdown of a substrate. It might be a carbohydrate, protein, or fat. I would like to emphasize on the study which was done in our unit. Professor Marianne Chapman, who is my supervisor, was one of the principal investigators of the study. It was published in 2008 in NEJM. It's called the Target Trial, which compared 1 kilocalorie versus 1.5 kilocalorie nutrition in critically ill and did not find any difference in clinical outcomes. And in that trial, they provided 70% of the calorie requirement in the 1 kilocal group and 100% of the calorie requirement in the 1.5 kilocal group, and there was no difference in clinical outcomes. So once you know that you have to provide, for most of the patients, the rule of thumb is to provide 25 to 30 kilocalories per kg, because these patients are considered as a higher risk for malnutrition. And for an elective post-op patient, we should calculate calorie requirements as 20 to 25 kilocalories per kg ideal body weight. To meet the patient needs. The exception would be in undernourished patients. You don't want them to go into refeeding syndrome. Thus, you give 25% less of the calories that you have calculated. In overweight patients, you give 20% less of the calories just to promote permissive underfeeding in these patients. The whole point is to ensure that muscle is not used up to provide energy and to give more protein, but restrict the calories from carbohydrate, because protein is now considered as one of the most important requirements for critically ill patients. But in all patients in whom the BMI is over 30, you do not deliver over 80% of the calories. In obese, overfeeding is definitely dangerous. So we only give 80% of the total calculated calorie requirement. So how do we actually calculate the energy needs? As I said, indirect calorimetry is the gold standard, but the overall energy needs is calculated by multiplying the basal energy requirement or the basal metabolic rate into activity factor and injury factor. BMR earlier used to be calculated with equations like Harris-Benedict formula, Schofield equations, but now we use indirect calorimetry for calculating BMR. And for our ICU patients, most of them are confined to bed, so we use an activity factor of 1.2, and those with the diagnosis of skeletal trauma and burns and sepsis will have a higher injury factor. This is the photo of indirect calorimeter, which is mostly used for research purposes in our ICU. And this has a canopy, and it measures the carbon dioxide production to the oxygen consumption for the breakdown of each substrate. Now comes the protein requirement. The current evidence, as per both ESPEN and ASPEN guidelines, is to provide 1.5 to 2 grams of protein per kg ideal body weight to meet most of the patient needs. There is something called non-protein calorie, or calories coming from carbohydrates and fats, versus nitrogen ratio. And this nitrogen, they say that it has to be 150:1. And you can calculate the nitrogen requirement based on calculating the nitrogen balance, which would be nitrogen intake minus output. And for every 6.25 grams of protein, it equals 1 gram of nitrogen. So the usual protein needs for no stress ambulatory patients is usually about, ambulatory people is usually about 0.7 to 0.8, but our ICU patients are under severe stress most of the times, and we tend to keep our protein provision between 1.5 to 2 grams per kg per day of ideal body weight. And how frequently do we do these assessments? Our dietitians usually do it once a week formally in those with normal renal function, and they aim to at least equal the nitrogen balance when they're calculating these protein needs. Then comes the fluid and electrolyte management. Nowadays, there are preformed feeds, types of feeds, which can help us cater to the fluid and electrolyte requirement of the patients. So there is something called isocaloric feed, which provides 1 kilocal per mil of feed, 1 cal per mil of feed. And you can give hypocaloric feeds, which provides 1 cal per 2 mils feeds, and hypercaloric feeds, or the 2 cal feeds, which provides 2 cals per mil, or 1.5 cal per mil, which was provided in the target study. And electrolyte requirements should be based on the individual patient needs. We don't prescribe electrolytes in enteral feeding as it is, but if somebody has hypernatremia, for example, then you can give low sodium feeds in those patients. And then you supplement micronutrients in those patients who have lesser micronutrients like B12 deficiency, vitamins, trace elements as per the recommended dietary allowance. And then you can incorporate into the formula feeds, which most of these feeds have it. Once you provide that, you assess for tolerance of these feeds in the patients by using something called GRV, which is gastric residual volume. Though there are several studies which have looked at no benefit of measuring gastric residual volumes in Australia. In most of the centers that I have worked, we measure gastric residual volumes every 6th hourly. And if the gastric residual, every hospital has a feeding protocol which tells what to do if the gastric residual volume is high. And the cutoff that we are currently using is 500 mils. If the gastric residual volume is over 500 mils, then we usually start prokinetics to promote feeding. As I said, getting a speech pathologist to review swallowing will help in patients who can take diet orally. And this is the GRV protocol. So if the gastric residual volume is over 500 mils in 2 consecutive measurements, then we withhold feeds and reassess the patient for feed intolerance, for patient tolerance. And we also start them on some prokinetics. Then comes the enteral nutrition. Timing of enteral nutrition. This is always the most important question, especially for anesthetists, especially for post-surgical patients. But the current guidelines recommend to start enteral nutrition as soon as possible, assess the tolerability, address the surgical concerns, and then watch for complications. There is something called trophic feeding and permissive underfeeding, which can be done in patients where you can't start enteral nutrition in the full capacity. Yes, so I would like to talk about trophic feeding and permissive underfeeding briefly. Trophic feeding has been practiced for ages, and the concept is to provide less than the minimum required calorie intake with an aim of maintaining gut integrity in patients in whom you cannot meet the complete nutritional requirements. It can be as small as 10 to 30 mils per hour of enteral feeding, or 15 to 25% of the calculated calorie intake. But trophic feeding has several advantages even in patients who have had gut surgeries, because it helps preserve the intestinal epithelium. It stimulates secretion of the brush border enzymes. It enhances immune function. It preserves the epithelial tight cell junctions, and it prevents bacterial translocation. There's something called permissive underfeeding, which is commonly done in obese patients, as I said before. So you provide a lesser non-protein caloric diet. You ensure that the patient gets 1.5 to 2 grams per kg ideal body weight of protein every time, but then you provide only 40 to 60% of the total calorie goals. And then it can be used as the sole nutritional strategy in most of the obese patients. But the advantages are you can use both enteral and parenteral routes. And there was a recent Nutri-REA study, Nutri-REA 2 study, which showed that there was no difference in clinical outcomes whether you use enteral or parenteral route. And it helps prevent fluid overload in patients like those with ARDS. And it also helps in calorie restriction, which possibly is related to longevity, as per our Indian thoughts. I'm sorry, there has been some issue with the slides. Yes, but one thing that you need to remember is to ensure that you don't cause a splanchnic steal by providing overnutrition. You should look for mesenteric ischemia, which is unusual, but still can happen in 0.02% of patients. This is what was noted in the Nutriria 2 study as well. And you also look for hemodynamic stability when you start feeding, because these studies showed that in patients with shock, starting them on gut enteral feeding can actually worsen the outcomes. So you have to be very careful to ensure that these patients are closely monitored when you start them on feeding. Okay, now comes parenteral nutrition. So whenever you decide to start a patient on parenteral nutrition, as described above, you calculate the energy requirements, and then using either indirect calorimetry, or you can use a reverse Fick equation. And then for specific disease states, you give extra protein, like in burns or hypercatabolic trauma patients, or you can give extra lipid, ketogenic diet in hypercapnic patients with COPD, or in patients with seizures. Once you confirm that TPN is the ideal step, the timing of starting TPN is different, and the guidelines vary on this. ESPEN says to wait for 2 to 5 days before you think of TPN, whereas ASPEN says wait for 7 to 10 days without enteral nutrition, without tolerating enteral nutrition when you decide to start on TPN. In our centers here, we usually wait for a week before we consider TPN in those patients in whom enteral feeding is a possibility. But if somebody has pre-existing malnutrition and you know that enteral feeding will not be feasible in a week's time, you actually can start TPN earlier. Whenever you think of starting TPN, you need to put in a central access. And whenever we do the TPN rounds in our centers, in our hospital, what we usually look at is to ensure that the care of the access is most important. Most of the patients actually do not have side effects of TPN, mainly because of fluid overload or anything. It is the care of the access sites, and ensuring that these don't get infected is the most important part. And this was what was looked at in Nutriria trial, as I said earlier. Sorry, it's just taking a bit longer to load the slides. So when you calculate macronutrient provision via TPN, you look at carbohydrate to fat ratio, and you ensure that it's 70 to 30 and you don't provide too much fat. And then protein, you have to ensure that you provide 1.5 to 2 grams per kg body weight. So fat in most of the TPN bags comes as a 10% lipid emulsion. You can also use a 20% lipid emulsion in fluid overloaded patients. And carbohydrate comes as 50% dextrose and protein as 10% amino acid solution. So 50% dextrose, it provides 1.7 kilocalories per mil, because the calculation is like, we used to know that carbohydrates provide 4 kilocal per mil, but dextrose as a preparation provides 3.4 kilocalories per grams. So that's why it provides 1.7 kilocalories per mil. And fat will provide 1.1 kilocal per mil. So you also add trace elements, vitamins, and micronutrients, but it's very important to monitor for blood glucose levels to prevent hyperglycemia, because you're basically providing intravenous dextrose. You look at renal function tests to watch for uremia and hypokalemia, and calcium, magnesium, phosphate, which is very important because you want to ensure that these patients don't have hypophosphatemia or refeeding syndrome. You look for LFTs to observe for steatohepatitis and acalculous cholecystitis. It's important to ensure that these patients are on thromboprophylaxis, and you look at the CVC site for infection, as I said. And most of these lipid emulsions are prothrombotic. They are egg protein and soy protein, and they are rich culture media, so they're more prone for infections. You have to ensure that these patients are watched for refeeding syndrome. As I said, it can cause massive shift of electrolytes intracellularly as soon as you give a large calorie and glucose dose. So you have to monitor electrolytes regularly and gradually increase the calorie and glucose intake. And this table describes the patients who are at risk for refeeding syndrome. Finally, this is my last slide, and I want to emphasize this. We will just go through how to calculate the calorie requirement or how to prepare these TPN bags. So if a 55-year-old patient is requiring TPN for bowel obstruction and postoperative sepsis, and you have calculated the ideal body weight as 66 kilos, you multiply it by activity factor and injury factor. And once you calculate the calorie needs at 25 kilocalories, which will come up to 1,650 kilocalories per day, you multiply by the factors. I'm not doing that here just for the ease of calculation. Then you calculate the protein requirement. I said you have to ensure that you have to give 1.5 grams per kg ideal body weight per day. So that comes up to 100 grams, which will provide around 400 kilocalories. And then you calculate lipid, which should not be over 30% of the kilocalories, which will come up to 250 mils or 500 kilocalories or 250 mils of 20% lipid emulsion. Then whatever remaining calories out of this 1,650, once you subtract the protein and the lipid calories, whatever remaining calories is there, that has to be provided with dextrose. So that's how you can calculate the final dextrose. So you add 446 mils or 50% dextrose into this preparation. So the final volume will come up to 1,696 mils per day. And when you divide it by 24 hours, you get roughly around 70 mils per hour of the TPN for a 66 kg patient. I would finally like to acknowledge my supervisor, Professor Marianne Chapman, who is my principal supervisor for the PhD, who actually has been instrumental in improving my knowledge on ICU nutrition, and also Dr. Trish for this opportunity. He is the director of ICU at the Royal Adelaide Hospital, and I really would like to thank him for this opportunity. And all my other supervisors and mentors and my colleagues for helping me with my studies in ICU nutrition. Thank you.